Today I'm going to talk about how we use digital technologies to implement and evaluate mental health literacy interventions to improve child and youth mental health, usually in the school setting. Okay, I'll just click on. Great, thank you. I just wanted to repeat some of the facts that everybody knows, and it's important to repeat because this addresses the importance of why we focus on child and youth mental health. And this slide summarizes studies from across the world from more than 40 countries to indicate that most of the mental disorders onset during child and adolescent years. Approximately 17% of mental disorders take place during adolescent and childhood and adolescent years. And then for individual disorders, you may notice that substance use disorder is one of the most prevalent disorders in this age cohort, followed by anxiety and depression and other disorders. Okay, hold on. And this, the slide I just summarized coincide with the suggestions and advice by DSM-5, which indicates approximately 70 to 75% of mental disorders can be diagnosed during childhood and adolescent years. Both highlights the importance to address child and youth mental health at this stage. However, unfortunately, the data shows us that approximately over 70 to 80% of people with severe mental disorders in low and middle income countries never receive needed treatment. And this number decreased a little bit in high-income countries such as Canada and the United States, but the number is still high. It's approximately half. Half of the population don't receive any treatment, even though they experience severe mental disorders. So the need for addressing child and youth mental health and the actual treatment rate makes a big gap in between to close up. Untreated mental disorders lead to a lot of consequences, including some severe physical conditions such as diabetes, heart disease, stroke, respiratory conditions, and suicide. Suicide is one of the most significant consequences of untreated mental disorders among adolescents and young adults. And untreated mental disorders also bring significant economic burden to the whole society. And for example, mental disorders, untreated mental disorders, and cardiovascular diseases combined together contribute the most to the economic burden of the global society. And if we calculate numbers, and this is data from WHO back in 2011, although this is old data, and it also gives us some insight. The most recent data has yet to come, but it indicates that by estimation, between 2011 to 2031, the estimated economic burden of untreated mental illness amount to 16 trillion. And because of the COVID-19, this number could increase significantly. So, untreated mental disorders bring us a lot of consequences to the society, and how do we address that? Especially when we talk about children and youth. And there is a foundational piece that everybody has to pay attention to, which is the approaches that we have using across the world, using the mental health literacy as a foundational piece to address child and youth mental health. So mental health literacy can be easily embedded in a school setting where most children and youth go to for education on a daily basis. And it has 4 interrelated components to address the understanding about mental health and mental disorders and related treatments, and obtain and maintain good mental health, and then strategies to fight against stigma, because stigma is one of the most barriers for help-seeking behaviors and intentions. And then once children and youth understand mental health and treatments, we have to enhance their help-seeking behaviors and intentions. So that's why we put 4 pieces together as a foundational piece for everything else we do, including mental health promotion, prevention, early identification, and care, and ongoing care. Without solid foundation, all the blocks above will fall. So a better mental health literacy will help children and youth have a better understanding about their own mind and their body and how they're connected together, and then they would seek promotional activities and take care of their mental health. And the mental health literacy approach is built on a population-based model. And this model was created in Canada about 40 years ago, and it has been evolved and widely implemented across 80 countries in the world. And this population health model is very simple. It has 3 diagrams that we can address. This model guides us to understand what we should address in terms of promoting population mental health, and how we address it, and who should be involved to address. At the very front of the block, you see a number of health determinants that may align with the mental health literacy approach. For example, the health determinants of social support network. By building mental health literacy in the school setting and in the community setting, we're able to build a supportive network to support child and youth mental health. And then we also addressed health determinants of education. Education is always one of the most effective ways to change people's behaviors. So by instill mental health literacy approach in the school setting, we are able to promote mental health in the educational system, and we are able to embed the mental health education in the regular classroom. And then we're able to address personal health and practices and coping skills. By teaching kids about mental health and mental disorders, we teach them how to use effective, helpful strategies to deal with and cope with their everyday mental health, and deal with and manage mental health challenges if they encounter those challenges in their daily life. And through that, we're able to build a healthy child development, and then to link education system with health care system together. And then who should be involved? We would say everybody in the community who deal with children and youth on a daily basis should receive mental health literacy interventions or resources. And centered around the circles I share here are children and youth, and then at least some examples of stakeholders in the community that we are able to work together to support child and youth mental health. And if you use this model in your setting, you may add in other stakeholders in your environment. But this is a Canada case. In our community, we engage a lot of teachers, parents, and police, and support staff, occupational therapists, and psychologists for sure, and system leadership together, working together. And you may add your list of stakeholders. For example, in China, you may add other stakeholders that we are not aware of. So different settings may have different customized support network. So based on this population health model and based on the concepts of mental health literacy, our team has created a series of a series of mental health literacy resources targeting children and youth at different age stage. For example, children and youth from elementary schools to secondary schools to post-secondary institutions. So at the very top of the slide, you see some examples of mental health literacy educational resources targeted for children and youth. And then at the bottom of the slide, you will see some cases and examples of training of stakeholders like teachers, parents, primary care providers, and some community organizations such as sports organizations in Canada, because sports organizations are very important in the Canadian settings because kids and parents usually go to sports after school. And that's where we reach to most of the children and their families. And training kids and parents and coaches in that setting will expand the reach out of mental health literacy approaches. By implementing and evaluating those mental health literacy resources in the community settings, we naturally build a pathway through care model from a wellness building to mental health literacy to early identification and triage between healthcare system and educational system to tertiary care to primary care and tertiary care. And the most important piece of the pathway through care model is not to send kids to the care system. And the most important piece of pathway through care model is to send kids to the healthcare system and then bring them back to the community. So that's the key piece of the pathway through care model. And we use the word through, it's a loop, it's a circle loop, going to the system and going back to community. So we didn't use the word to care, because if you go to care, you don't usually go back. So, and this is the circle we focus on. I would like to give some examples of the digital interventions and resources we have built so far. All the resources just shared can be accessed free of charge through our online digital platform called mhlcurriculum.org. I don't know if you can see this, but if you go to our website, you will see curriculum-based or ready resources, and you will see the first resource is called Curriculum Guide. It's designed for secondary school setting, and then you will see elementary mental health literacy resource designed for elementary kids starting from grade 4 to grade 6 in Canadian school systems. And different countries have different educational systems that you can customize the resources to be utilized in your school setting. And then we also have Know Before You Go, designed specifically for grade 12 students, the last year of high school students, to prepare them for post-secondary life. And then a companion program called Transitions that I show here is designed for first-year university or college students to help them transition successfully from secondary to post-secondary schools in the new setting called university or college campus, where students explore a lot of freedom and then enjoy a lot of freedom and new relationships and new environment while they experience a lot of challenges at the same time. So all these resources are either electronic booklet that students can freely access or online interactive modules that teachers can utilize directly in their classroom, or a hybrid model of both in-person or online learning modules that students and teachers can access. This website is called teachmentalhealth.ca, and this website is designed for teachers, pre-service teachers, or any stakeholders who work with children and youth and who really wanted to improve their understanding and to achieve a comprehensive mental health, comprehensive understanding about mental health. And this is where they can go to learn and teach. and learn about mental health and how to address child and youth mental health. And this is a website that hosted by University of British Columbia, Faculty of Education, for free of charge. And it has been accessed by many educators from across the world that I'm going to talk about. Then we ask ourselves a question: how do we decide an online accessible resource different from in-person training? So we wanted to reach to as many educators and parents as possible. And in-person training may not be the most plausible way to reach to so many teachers and parents. But we designed this online resource, but we wanted to understand how this works. And in order to achieve this better understanding, we designed a 3-arm study using face-to-face and online training module versus control group to understand how these different 3 different delivery modules, methodologies different from each other. And it turned out, we found, there is no significant difference between online delivery of teacher or parent training versus face-to-face in-person training delivered by professionals from our team. Compared to control groups, both face-to-face and online training modules made significant improvement among teachers and parents in terms of their understanding about mental health and in terms of their positive attitudes towards mental health and their understanding how to seek help for children and youth. So we are more confident about these 2 delivery modules because sometimes schools request in-person training and some schools request online training. And then we specifically designed a go-to-educator training to understand if this type of training in the school setting, either in person or online, can support school staff, for example, teachers or any other school staff, including school bus drivers, cafeteria staff, and administrators, anybody who can support child and youth mental health. We identify these go-to educators to understand if by training them we would improve the quality of referral as well as their understanding about mental health. When we started with almost 500 educators across 6 provinces in Canada. We are able to find that this type of training is very effective in terms of improving teachers' understanding about mental health and improve their attitudes towards mental health. Then we further evaluated how this type of training will improve the quality of referral between schools and healthcare systems. And we did a large retrospective controlled study in one of the largest cities in Canada, and we engaged more than 500 schools, and it turned out close to 500 schools eventually participated in this retrospective study. In this study, we tracked down all the clinical profiles of children and youth who are referred from schools that had received go-to-educator training versus schools that waited to receive this type of training. And then we compared clinical profiles of children among these 2 different groups of schools. And we found out that schools from intervention schools, children from intervention schools, they are younger when they were referred to tertiary care, indicating early identification of children and youth who needed care and received care appropriately. And then this case also demonstrated more severe symptoms and demonstrated more harmful behaviors and thoughts. And that indicated the quality of referral improved because kids who really needed care, they were referred to care because they demonstrated more severe symptoms and more harmful behaviors compared to kids from waitlist schools. And they were less suicidal. This is a very interesting finding because in Canada, children and youth who had suicidal thoughts and behaviors, they were not usually dealt with in the tertiary care, but instead they were sent to specialty care dealing with suicide in the community settings. And that's why we saw less kids who demonstrated suicidal thoughts and behaviors in the tertiary care. And they stayed longer because they had more severe symptoms. And what is more important is that when they were discharged from the care system, they demonstrated more improved outcomes at discharge compared to kids from waitlist schools. And all these indicators demonstrate a significant improvement of quality referral from the school system to the healthcare system. And then we further developed primary care provider training and targeting non-clinician primary care providers. And this is a special case in Canada. I don't know how it is in China, but in Canada, there are other non-clinician primary care providers working in the primary care settings, and we identified them as a key player in addressing China youth mental health care. And we trained them on how to early identify signs and symptoms and provide appropriate, very preliminary care before they see primary care providers like family doctors or other professionals like psychologists and psychiatrists. And they all improve their knowledge and understanding about early identification and improve their attitudes. And then the qualitative study we had with them that I didn't share here indicated that they all improved their practices in their everyday working settings. And here I wanted to just emphasize one specific resource we have used across more than 20 countries in the world, which is the Mental Health and High School Curriculum Guide, and the first ever evidence-based, curriculum-based interventions that have been used in Canada. First in a number of provinces, including Nova Scotia, Ontario, Alberta, and British Columbia. The first study we did, RCT study we did, was with 36 high schools in Ottawa region in Canada, demonstrating significant improvement of knowledge among students and also behaviors in help-seeking intentions and behaviors, coping skills and coping management skill sets all improved significantly. And that study was replicated in Wales. And Wales last year published a study engaging almost 2,000 students, but with age justification, because when we did a study in Ottawa, we targeted the last year of secondary school students who were ready to go to post-secondary institutions. While in Wales study, they targeted students aged between 13 to 15, while demonstrating very similar results: improvement of knowledge, reduced stigma, and improved help-seeking behaviors, and improved coping skill sets. And this study was a groundbreaking study because this is the first time that an RCT study in mental health literacy that was successfully replicated in another social and cultural settings. So I just talked about this. And then we just found a recent meta-analysis, systematic review and meta-analysis focusing on this mental health literacy intervention. And this is the first ever school-based mental health literacy intervention that has demonstrated robust results in terms of all mental health literacy outcomes from 8 countries. The Know Before You Go study is relatively new that we just piloted with a number of rural schools in Nova Scotia, which demonstrated improvement of knowledge outcomes and reduced of stress. And this is very significant pilot preliminary study because the purpose of this resource is to help students to smoothly transition after high school. And then during this stage, students always demonstrated a high level of perceived stress. And our study indicated Know Before You Go resource, by embedding in the classroom, is able to demonstrate reduced stress levels among students. A similar companion study is called Transitions. We did a study among more than 2,000 students demonstrating similar results to the Know Before You Go program. The elementary resource is relatively new as well and launched last year in Alberta province, and we did a pilot study engaging almost 4,000 students in Alberta province, and all outcomes have very positive, and that enables us to have more schools to join in the following years. And now we're recruiting schools from other provinces like Nova Scotia, New Brunswick, and British Columbia. We also value the cultural component of mental health literacy approaches, which engaged us to invite communities from rural part of Canada and from Indigenous communities across Canada. Right now, we're funded by CHR, a large health agency in Canada, to adapt and recreate a new resource for Indigenous youth in Canada. And we have engaged a lot of communities to provide feedback on how to build this resource together. So it's a community participatory resource that we have been working with different groups in Canada. And the next stage of our mental health literacy approach will focus on AI-empowered technologies. We have used a lot of online interactive strategies to engage students, parents, and teachers, and now it's time to engage AI and to support China youth mental health. And we have planned to apply for a grant to build an AI-powered systematic comprehensive path through care model in which we're going to input promotion, prevention, early identification, and system navigation components together to address child youth mental health in Canada. This is some numbers that we have used for the past 5 years through in-person training. We hope with AI technologies we're able to double, triple the engagement of teachers and parents. And large online modules called MOOC courses delivered and hosted by UBC Faculty of Education will be adapted using AI technologies in the future. And currently we have collaborated with more than 20 countries using mental health literacy launches, and hopefully with AI-powered technologies, we're able to reach more regions and countries in the future. And this is my presentation, and I'm happy to take any questions or comments or concerns. Thank you.